My name is Gay Grossman, and I lead the patient advocacy and engagement at GeneDx, and we're very happy to be here. Thank you for having us. I work with the advocacy organizations that are around the country, all different levels of umbrella organizations to disease-specific organizations and gene-specific organizations. And we're very lucky to have with us tonight Olivia Trimmier, and she is a genetic counselor and oversees all of the MSLs that work at GeneDx. And if you would, Olivia, introduce yourself and then maybe explain what an MSL's role is at GeneDx.
Sure. It's nice to virtually meet you all. Thank you for having me. I am a genetic counselor by training, as Gay said, which means I spent a lot of time in clinic, in direct patient care, working with families who were undergoing a genetic diagnosis or receiving a genetic diagnosis or were curious about their own genetics. And currently, I work at GeneDx as a medical science liaison. So I no longer see patients in my current role. We have a whole team of genetic counselors dedicated to patient-facing care, but I serve as a liaison between providers who are ordering testing and the laboratory. So I help providers understand how to use genetic testing, what sorts of patients could possibly benefit from genetic testing, and then also help on the back end with understanding the results and whether additional follow-up would be needed based on the genetic testing results. Should I get started? Okay. This is a conversation, so please feel free to ask questions if something I said doesn't make sense. I am a fast talker. I'm from Maryland, so as a fellow Northerner, I can run through things really quickly. And I do recognize that genetics is a foreign language. It's really hard to understand some of the nuances here. It is sort of like learning a different language. And so some of the terms are new. Maybe you've come across these before. I'll do my best to explain it to you. But if there's any place I can go back through and clarify, I'm always happy to do that and happy to answer questions as they pop into your mind if you feel like you'll forget them if you don't get them out. So today we're going to be talking about advances in epilepsy genetic testing. And why do we want to talk about epilepsy and genetics? It's because the vast majority of patients with epilepsy do have an underlying genetic cause or reason for their epilepsy. So recent systematic reviews, which is basically an amalgamation of many different publications looking at epilepsy genetic testing specifically, found that up to 48% of individuals with epilepsy have an underlying genetic cause that can be determined through genetic testing. I am going to go through three things in this presentation. First, we'll talk about genetic testing fundamentals, so really setting the language for which we speak about genetic testing. Then we will talk about the different genetic testing strategies. It's changed a lot over the years, and you might have heard of many different types of genetic tests, but we'll talk about where we started and where we are now. And then something that's very near and dear to our hearts at GeneDx, which is making genetic testing accessible. We don't want the diagnosis to be a barrier for patients and their families. We want to make sure everyone can benefit from genetic testing who feels like it would be useful on their journey. So let's dive into the genetic testing fundamentals. All right, we're going to take you back to high school biology class, everyone's favorite subject. Really what we're speaking about are genes, and genes are the instructions that tell our body how to grow and develop, how to break down our food and help our muscles and function our brain. Our genes are packaged into what we call chromosomes. And there are 20,000 genes packaged in these little chromosomes. We all have 46 chromosomes. They come in pairs. So we get 23 chromosomes from our mother, 23 chromosomes from our father. So we have one chromosome from mom, one chromosome from dad. The only exception are the sex chromosomes, the X and Y chromosome. For females, you get an X chromosome from each parent, from mom and from dad. But for males get an X chromosome from their mother and then a Y chromosome from their father. So that's the only place where there's not exactly two of every gene, two of the same chromosome. Within the genes are little instructions that basically tell the gene how to function properly, how to do its job. And that the gene is made up of a string of DNA letters, essentially like a DNA alphabet. And those letters are A, T, G, and C. They repeat in many, many different combinations within your gene to give the instructions for the function of that gene. There is a lot of variation that can happen within those letters in the ways that the A's and T's and G's and C's are put together. And variation is good, right? We like diversity. We know that we're not all the same. And a gene that tells you to make a blue eye versus a gene that tells you to make a brown eye, that's all the same variation of normal, right? But there are different instructions telling your eye cells to be blue or eye cells to be brown, but it's not necessarily a problem. However, sometimes the letters get rearranged in a way that causes the gene not to work. It might not work at all, or the gene might be missing, or the gene just might be a little bit impaired. It might not do its job to its fullest capability. And that is what we historically referred to as a mutation. We've gone away from that language in recent years, and we typically call these pathogenic or likely pathogenic variants. Pathogenic means disease causing. So if something is a disease causing variant, if it's problematic, then we call it pathogenic variant. If a variant is most likely disease causing, then we call it a likely pathogenic variant. But those are the words we use now to kind of describe something that is a variation of normal, but that causes some problems because of the variation. I don't know who has heard this analogy before. This is a very common analogy in the genetics world, but we like to think of our genes and our chromosomes and our DNA as a book or a bookshelf. Sometimes we use the analogy of a cookbook, where your DNA, all 46 chromosomes, all 20,000 genes, that is the entire cookbook. And then your chromosomes, those 46 pairs of chromosomes, those would be the chapters in the book. So let's say we were using a cookbook as an example. You might have a chapter on salads and a chapter on entrees and a chapter on desserts. Those are going to be your different chromosomes. And then the genes are the individual recipes within each chapter. So your salad chapter, your salad chromosome might have, 5 different salad recipes in there, or 5 different genes that live on that chromosome. We can also translate this into the type of testing that's offered. So historically, what testing has been available for the most part are these two tests on the right-hand side. So your chromosomal microarray is a test that has been around for a very long time. It was typically considered the first test that we would do if there was suspicion of a genetic disorder. And the chromosome microarray is really looking at those chapters. So looking at the salad chapter, looking at the dessert chapter, and it's looking to see if basically the chapters in the book are all present and accounted for. So we might look at someone's chromosome microarray and say, hey, there's not a salad chapter. There should be a salad chapter, but it got deleted out. Or there are 2 salad chapters. It was a duplication of this chapter. Or sometimes we can tell that, hey, instead of 5 salad recipes, there's only 1. Where did the other 4 salad recipes go? So we can sort of see that the chapters themselves are whole or missing, or maybe that there's extra. We can also look at specific gene-based testing. So the chromosome microarray, while it's going to look at the chapters, it's not actually going to read through the recipes and make sure that all of the recipes are spelled correctly and the instructions are clear. And so we also were able, historically and currently still, honestly, to look at those individual recipes within the chapter, look at those individual genes within the chapter, and see if they were all correct. Sometimes laboratories will just look at one recipe, so one gene, and sometimes they'll say, you know, I want to look at all of the recipes or all of the genes in the salad chapter. So I want to put all 5 genes together and read through them and make sure that they make sense and they are following the right order and can make a good recipe. Labs will offer kind of a single gene test or multi-gene test. So there can be tests that look at just one individual gene. And then sometimes labs will have what they call a multi-gene panel where there are hundreds of genes or hundreds of recipes in there. The newer testing methodology and where the world is moving is towards something called whole exome or whole genome sequencing, which is on the left here. And the beauty of whole exome and whole genome sequencing is that you really get everything from those smaller tests. So not only will it look to see if all the chapters are there, the chromosomes are there, it'll make sure that there aren't missing chromosomes, missing chapters, extra chromosomes, but it can also read through all the individual recipes. So it can look at all of the individual genes at once. So it's really like combining multiple tests into one test and looking at the cookbook in its entirety, but also at kind of a holistic view, but also at a very minute view as well by reading through every recipe. And the benefit of that is the chance of finding an answer is so much higher with exome and genome sequencing as compared to these previous testing options. When you're only looking at part of your DNA at one time, if you're only doing a microarray or only doing a panel, the chance that you're going to find an answer is not super high. It's somewhere in the ballpark of, you know, perhaps 10%. So most often you're going to get a negative result. You're not going to find an answer because you're really not looking at the whole picture. You're just looking at part of the picture. But whole exome and whole genome sequencing, because we can look at the entire picture, your entire cookbook, we typically see a higher chance of finding an answer for patients, usually starting at about a 20% chance for answers and going up from there to, you know, depending on what we're talking about, you know, upwards of 40, 50, 60% chance of finding an answer. So as I mentioned, about 48% of patients with epilepsy have a known genetic cause, and the way to make sure we can identify all those patients, we can find the individuals who have an underlying genetic cause for their epilepsy is sometimes by doing more comprehensive testing like whole exome or whole genome sequencing, either right out the gate if no testing has been performed or as a follow-up if prior testing has failed to yield an answer. Moving towards what is out there in terms of what the experts recommend, there have been a lot of advances in recent years. As I mentioned, the chromosome microarray and those multi-gene panels, they really were standard of care for the last decade or so. But things have been changing in the genetics world. Everything always changes in genetics. And we're moving more towards an exome or genome first approach. So the American College of Medical Genetics recommends exome or genome as a first-tier test for any individual with developmental delay, intellectual disability, or birth defects. Sorry, I'm going to cough. Okay. This is because the diagnostic yield is much higher, as I mentioned, and because it's a more complete test. Following this, the National Society of Genetic Counselors put together a systematic review, basically reviewing all of the literature that exists in the epilepsy genetic space. And they put together recommendations for exome or genome as a first-tier test for individuals with unexplained epilepsy. Sorry, everyone. The interesting or important thing about this is that it was regardless of age or the presence of any other comorbidities. So sometimes you'll hear providers say, well, you should only do genetic testing if it's a young child, or you should only do genetic testing if that individual doesn't have good response to medication. But really, it's any individual with unexplained epilepsy should have the option of undergoing a comprehensive test like exome or genome. This recommendation was endorsed by the American Epilepsy Society shortly after its release. And so we were really excited to see that they mimicked the National Society of Genetic Counselors guidelines. When you receive a genetic test result, it can sometimes be complicated to navigate through. There are many different types of results we can get from genetic testing. And this is really regardless of what test we're talking about. So it doesn't matter if you had an exome or genome or microarray or a panel, the types of genetic test results you can expect are all the same. The first type of test result we see is a positive or diagnostic variant. So that's that pathogenic variant or likely pathogenic variant I mentioned before, meaning we found an answer for what is going on for this individual. We found an explanation for the symptoms. We found an explanation for the epilepsy. The other more straightforward type of result is a negative result. So negative or non-diagnostic means at this time, there were no genetic variants or genetic changes that explained why someone had epilepsy or has epilepsy. I would caution here that a negative result is only dependent on our understanding of things as they stand, and is dependent on how good the technology is at that given time. It does not mean that there is no underlying genetic cause. Certainly you can tell if major things were ruled in or out, but there could still be a genetic cause for a patient's epilepsy with a negative report. It might be that the technology that was used just didn't detect what was going on with that patient, or our understanding of science hasn't caught up with things. So sometimes we discover new genes we didn't know about on previous test results. These are called candidate genes. And as more research is done about them and we establish a clear disease gene association, this might change over time, and someone's previously negative test result might become positive in the future. So it reduces, but does not eliminate an underlying genetic cause. I know that can sometimes trip folks up, so I'm happy to chat that through further. The third category, and this is the category that is definitely the most confusing for providers and patients alike to understand, is when we find a change, we find a variant, but we don't really know what it means. So we see something, we see a spelling mistake, but we don't really know if that spelling mistake in the recipe means that the recipe will turn out okay or not. And a lot of times when we identify a variant of uncertain significance, we will sometimes recommend follow-up testing for other family members, or we might recommend that we just kind of wait and see how many other patients eventually are tested who might have the same variant, to see if that changes how we think about it. So, we might have said, oh, we've only seen this variant once. We don't really have a lot of information about it. But in 3 years, if we've seen it 20 times, and we know that it's found very frequently in healthy individuals, we might change that variant of uncertain significance to a negative report. We might say, okay, we've seen this enough. We know it doesn't do anything. We know it just, changes the temperature on the oven, but the cake still turns out great. And so we can update a report and call it negative. Sometimes we get new evidence and we say, oh no, actually, now we have enough evidence to show that this variant of uncertain significance is actually problematic. If you don't add baking powder, your cake is going to fall flat. And so we know that this causes changes that are going to be damaging to the how the gene operates. And so we're going to change this and turn it into kind of a positive result, or upgrade it. So that's a really hard category of results for families, that uncertainty of we don't really know much about it yet, and we've got to hang tight and let science catch up to us. Moving into genetic testing for epilepsy. So I've mentioned this already, but there is an underlying genetic cause in epilepsy in up to 48% of individuals. So it's definitely something that is on our mind whenever we have patients who are diagnosed with epilepsy, that there could be something genetic that is causing the features, causing the symptoms for the patient, and they could be a good candidate for genetic testing. Epilepsy impacts 1.2% of the US population. And we know that genetic testing in epilepsy can be really helpful. It can lead to more effective treatments, something that we call precision medicine. And it can also help identify, treat, and or prevent co-occurring medical conditions in children with epilepsy. There is a lot of genotype-phenotype correlation in epilepsy, meaning if we know what a gene does, then we can sometimes make an impact on the symptoms or the phenotype of the patient. So in epilepsy specifically, that might mean, hey, we know this gene, doesn't respond well to anti-epileptic medication. It responds better to diet. And we can make those modifications, what we call precision medicine. We also know that genetic testing can sometimes help with seizure reduction. So, for example, in that case I mentioned where we know that a ketogenic diet would be helpful, especially for patients with, for example, GLUT1 deficiency. We can impact the seizure control with a more targeted treatment approach. And then we are just living in an age where more and more is being done to impact precision medicine to be able to treat the gene itself that's causing the symptoms or the phenotype. And so knowing an underlying genetic diagnosis for patients, while it might not have any medical treatment now, it could be that there's treatment later, or that there's a clinical trial later that patients might be eligible for. I have this discussion a lot with providers who will say, well, the seizures are well controlled. I don't think genetic testing would be helpful. And that I still think that there is a room there for patients to have access to genetic testing, because there might be better treatment down the road, or they might stop responding well to treatment now and be a candidate for something in the future. So I think this is just exploding more and more. And right now there are about 66 genes that cause seizures that have specific medical management and treatment recommendations, but that's only going to improve as we learn more. These are some of the conditions I spoke about that have medical management implications. So I mentioned GLUT1 deficiency already, which is caused by the gene SLC2A1, or rather changes in that gene, because we all do have two copies of that gene. It's only changes in the gene that can be problematic. And as I mentioned, the typical treatment for patients with GLUT1 deficiency is to modify diet, to go on a ketogenic diet. There are also other conditions where there are certain medications you might want to avoid, or certain medications you might want to implement. So for example, cerebral folate deficiency, supplementing with folinic acid can be really helpful for those patients in their seizure control. As a genetic counselor, I am a big proponent of genetic testing and really strongly believe in its value. I find that, genetic testing is definitely a personal decision for families. And it's really about understanding how it would help you and what it might give to you. So for some families, genetic testing is simply just the route that they're undergoing to try to end a diagnostic odyssey. They have searched for answers for years and years, and they finally get an answer through genetic testing. And it can be a huge sense of relief for some patients, or kind of bring everything into view, into focus. For some patients, genetic testing can help develop that more precise care plan if there are, if they have an underlying genetic condition that responds to particular treatments, or avoiding treatments that might not be necessary or that might be contraindicated. Sometimes it alerts us to additional health risks that we need to be monitoring. And also it can increase the patient's network. Some families feel like, they don't have an answer for what's going on, or maybe they do have an answer, but they want to talk with other families who are also going through the same sorts of things that they're going through. And so being able to connect a family with a community, particularly a community of patients who are similar to them or similar to their family, can be really impactful and powerful. We all want a community, and I think that is something that parents I've spoken with have found really valuable about genetic testing. Let's talk about making genetic testing accessible. So years and years ago, actually not that many years ago, probably just 2 or 3, the only tests that were accessible to patients based on insurance guidelines, based on medical policy guidelines, professional society guidelines, and cost were those smaller stepwise tests like the chromosomal microarray and the multi-gene panel. Things have really changed over the last few years because the professional societies have advocated for an exome or genome first approach. The insurance companies have really come on board and started covering exome and genome as a first line or first test for patients, for more indications. And we're seeing that more health insurance plans have coverage for exome or genome sequencing than even sometimes those multi-gene panels. So it's really nice that more patients have access to better genetic test results. We know exome and genome have a higher chance of finding an answer for the patient. It ultimately can help reduce their overall healthcare dollar spent by not having to pay for a microarray and then a panel and then an exome. Starting with just one test is a better scenario for patients. Medicaid varies. So most state Medicaids are starting to cover exome sequencing, not quite yet genome sequencing unless it's in the NICU, the neonatal intensive care unit. There is some coverage there for that. Many laboratories don't necessarily balance bill Medicaid patients. So if you ever have genetic testing, depending on your specific insurance plan, whether you have a commercial insurance plan or a Medicaid plan, I always encourage you to inquire with a lab that you're using for genetic testing about how their billing works and whether they are in network or out of network with your specific plan. Sometimes insurance does make us jump through a few hoops in order to get exome or genome covered. So for example, an insurance company might have specific criteria that has to be met. So you have, the onset of seizures has to be before 18 years of age, or there have to be, multiple different organ systems affected for testing to be covered. So it's really a case-by-case basis with an individual insurance plan. Most insurances have pretty broad coverage, but there can sometimes be those, hoops that we have to jump through. Additionally, sometimes they require additional documentation. So some insurers like to see pre-test genetic counseling or post-test genetic counseling by either a genetic counselor or a geneticist, which is a medical doctor who specializes in genetics. Sometimes they have additional forms that they want the provider to fill out, explaining that they want to go for an exome or genome first approach, because, and kind of making the case for that. So really, there can be a few additional hoops, but most providers are very well versed in these nuances and are able to meet the needs of the insurance company. And I know a lot of the laboratories like to make sure that their providers are aware of what the laboratories are asking for so that they can make sure patients have access to this testing. If you ever have questions about genetic testing or family history, or you have genetic test results you don't know what to do with, genetic counselors are available. The National Society of Genetic Counselors does have a section on their website where you can find a genetic counselor local to you. I always encourage patients and providers to use their local support network. And if you have access to a genetic counselor locally, to make sure to make an appointment there if you feel like that would bring you some help. A lot of laboratories will have the genetic counselors on site as well who will speak to patients. So for example, at GeneDx, we do have a genetic counseling team that speaks with patients. We offer pre-test genetic counseling and post-test genetic counseling, and they are full genetic counseling sessions where we look at the family history and we can explain how the test works. And then on the back end, we can review the results and connect a family with resources. So we really like to partner with families and providers and making sure that everyone is comfortable with the testing being performed. They understand its benefits, risks, and limitations, and that on the back end, there is someone supporting you through either a new diagnosis, a negative, genetic test result, or an uncertain test result.